Okay, I think we can start now. Assalamu alaikum and good morning, everybody. Welcome to the BSAPCH interview workshop, and also good afternoon to those who are joining from the east of the globe. It is with pleasure to present Dr. Saif Babikir. He is a previous consultant neonatal pediatrician and the current president of BSAPCH, to welcome everybody and give us a short talk about the association. Please go ahead, Dr. Saif.
Thank you. Can you see me? I lost some of the screen, I don't know.
Yes, we can. Yes, we can.
Oh, you can see me?
Yeah, yes, we can.
Yeah, that's fine. Good morning and welcome, everybody. I'm delighted to be welcoming all of you to this very important event. Firstly, I would like to say a few words about the British Association of Pediatricians and Child Health, BSAPCH. Next slide, please. Can you make the slides big? I can't see it. It's very small. I don't know what happened to my screen.
The screen is maximum, but I think you need to maximize your own screen.
I did something. I don't know what I did. Technology goes wrong. There is a full screen. It's just the slide is very small. I've been trying to.
It's actually full screen slide. I think it's just on your setting.
Yeah, that's fine. Yeah, it's fine now. So our association is an academic, non-political, benevolent, in other words, charitable organization established about 17, 18 years ago. And I'm proud to be one of the founding members. We very carefully chosen to name it BSAPCH, adding child health. So it's not exclusive to doctors. Anybody interested in child health or well-being of children are welcome to be a member or associate member. We work over the years, we have worked in very close collaboration with our sister organization in Sudan, Sudanese Association of Pediatricians. We were very active in the first 10 to 12 years. We attended numerous conferences. We organized workshops. We did contribute to lots of charitable activities. However, we went quiet in the last few years as most of our members expatriated to the Gulf countries and some of them went back to Sudan. The association is currently in the process of reinvigoration thanks to the young Sudanese pediatricians who joined the association, and they are actively recruiting more members. So therefore, our priority now is to look after our members, especially in terms of mentoring and career advice. Next slide, please. Interviews. I think the first time I was in an interview panel was probably 25 years or more than that in this country. And over the years, I've seen significant changes happening to the interview structure and the way it's carried out. I haven't been an interview for the last 4 or 5 years since I've retired, although I'm still working part-time. But the interview process has become more fair and transparent. The assessment is objective. There is a fair scoring system. And over the years, I've seen more and more representation of non-medical members in the interview panel, especially when interviews are carried to appoint a middle grade or a senior pediatrician. The impressionist attitude, which I want to call it, has been largely eliminated, although not completely. Would I feel comfortable if this doctor is my registrar tonight? That used to be a common scenario in the old days. I don't think this would be allowed nowadays. Next slide, please. So, are you good at selling yourself? Do you have any skills in the art of marketing? I think this is a big question. So you need to know how to sell yourself, even before you apply, when you apply, and if you are shortlisted, then you are definitely appointable, but you may not be appointed. Why? Maybe another candidate outperformed, something went wrong. Did I dig a hole for myself? And I'm sure our faculty members today will answer all these questions. Try to reflect. Of course, you do get feedback from the panel if you did not get the job. But if the feedback you got, wow, well, doctor, you've done really well, you are definitely appointable, blah, 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 blah. But somebody else perform better. So your aim in the future should not just to be to perform well, but to outperform. So if the feedback is constructive and there were things that went wrong, then you need to make your plan for future applications. This is just a few words, and I'm sure the candidate today will benefit a lot from this workshop. And once again, I would like to thank everybody, especially the faculty members who sacrificed their Saturday and volunteered to participate in this workshop. Thank you.
Thank you, Dr. Saif, for the short and concise introduction. I would just like to welcome everybody again and say a few words on how the day will run. A lot of, actually all of you have received emails about details of the day and the schedule of the day, and the morning sessions will be informed by generic short presentations, starting with Dr. Simon Broughton in just a few minutes from now. These are just intended to give you a broader idea of the topics and the stations discussed in the interview. There will be a short break in the morning sessions between after two presentations, and then we will be back on the presentations again until just before noon. We are going to come back in the afternoon at about 12-ish to split all the candidates and everyone into rooms to start the mock sessions. I'll just remind everybody that activities during the day are being recorded just for archiving purposes, but none of the material is going to be used or published without the consent of the presenters and speakers. We kindly ask you all to keep your videos on during the mock sessions. We understand that sometimes connections may have trouble, and if you think your video needs to be off just to make connection better, that is completely fine. But during the mock scenarios, it is better to keep it on, as part of your assessment will be assessing your non-verbal gestures also. At the end of the day, we will be sending you a link for an online feedback. It will be really helpful for us to know how we did and how the day went on, because it just makes it easier for us to plan future events and make it better. Please feel free, if you have any questions during the sessions, to put them in the comments, and the moderators will be able to relay to the speakers. If you want to share a verbal thought or a verbal question with us or with the speaker during the session, please keep it to the end of the session, and just if you click your raise hand up, and you'll be given the chance to do that. And hopefully the day will be very useful for everyone, and good luck to all. I'm now going just to pass the microphone to my colleague, Dr. Iman, to present Dr. Simon. The mic is yours, Iman.
Thank you, Hani. and thank you everyone for being with us this morning. I would be pleased if everyone can just keep the microphone mute while the speaker is presenting. And please drop the question in the chat box. We'll answer them at the end. So our first session, we are honored to have Dr. Simon Broughton, who is Consultant General Pediatrician at King's College Hospital. And he will talk about prepare yourself for interview. Dr. Simon, you have 20 minutes. I'll just remind you at 5 minutes before the end of the session. You are welcome, Dr. Simon.
Many thanks, everybody, for inviting me along to give this presentation. So I'll start off with apologies because I haven't got any slides, but everything I'm going to say is on the RCPCH website. So you'll be able to follow up with a kind of resource acquisition from there. So I'm a general paediatrician and clinical director of the whole of child health at King's. So you could imagine I've been quite busy recently with COVID. We've got over 700 patients across our two sites, which is a bit of the reason why I've not had the time to prepare the slides. So sorry about that. So application to ST1 Pediatrics this year is going to be fairly significantly different from what's happened before because of making it COVID secure. Completely following on from what the previous speaker said, you know, the interview panels, the number of interview panels that we've had in the past have certainly helped to standardize the application process and make it fairer for all, really, and to kind of help to remove any unconscious bias which may creep into any interview process. However, this year it's going to be significantly different. So what I'll do, if it's okay, I'll run through what's going on this year. I'll talk a bit about the interview itself, my tips for the 3 stations on the interview, and then I'll be happy to take questions. So you'll all be familiar, if you're applying for ST1, that you need to get the Msra assessment completed, and I think the deadline for that is coming up. I think it's the 18th of January is the deadline, but please check the information you needed to sign on and get yourself registered for the Msra. And then there is an application form. Now, whereas previously the application form was really just for information and then helped us to look at the career motivation station, this year the application form is being marked. And the reason for that is giving us a plan A and a plan B. If COVID becomes so bad throughout the country that we're unable to carry out interviews, then we need to have some way of assessing candidates so that we can still fill the posts. And we had an absolute disaster in March of last year, where we weren't able to interview the ST3 and 4 applicants. And we purely went on their application form, and we hadn't told them that that's how they were going to be assessed. We just had to roll with the punches that COVID was throwing at us during wave 1. We're much more organized now in wave 2. And so we've got the 3 methods of assessment, which are Msra, the application form, and the interview. So the Msra will take up 20% of the assessment of the total score. The interview form 30%, sorry, the application form 30%, and the interview 50%. If the interviews are unable to go ahead because the faculty are too busy, which is, I think, highly unlikely, given the number of trainees that we've got who have already volunteered to help out with interviews, then it will be 40% for the Msra and 60% for the application form. So really, really, really important to get the application form as strong as possible. I think they've all been submitted already. So the interview itself consists of 3 separate components. The first component will be a communication scenario with an actress. Now, clearly this is going to be challenging over the internet using a Teams or a Zoom-based approach. It'll probably be a slightly different platform to that, or it may be one of those 2 platforms. Nevertheless, you're going to need good internet, broadband support from home, so that you can get access to the interview, and no distractions. So if we've all got children who are studying at home at the moment, we know what distractions are like for them when they're doing their online lessons. But the communication station, so bearing in mind that we don't assume any knowledge of pediatrics beyond medical school for ST1 applications, but we assume that the candidate will be able to apply F2 level competencies to that knowledge. So, so we won't expect the candidates to be able to tell us the biochemical abnormalities in pyloric stenosis, for instance, but we would expect them to be able to say that putting oxygen on in an emergency, working collaboratively with the team, using an ABC approach, early escalation, would be something that we would expect. So the communication scenarios, you'll speak with an actress or an actor about a particular scenario. The majority of the children in the scenarios, I've done all the questions, between the ages of 6 and 16. I've put in some elements around sort of COVID anxiety, but haven't particularly made COVID part of the scenarios, because I think that overcomplicates it. But nevertheless, I think it's important that we do recognize the anxiety that's out there amongst our patients from COVID. So the next part of the interview itself is the career motivation section, where we speak to you about why you want to do pediatrics, who your role models are for wanting to do pediatrics, what you think are the attributes of a good quality pediatrician, and then how you see yourself going forward in the future in terms of your career. But really the key thing is kind of really describing why you want to do pediatrics, and then describing your role models and why they're your role models. And then thinking about the attributes that you think will make an excellent pediatrician, and hopefully you can use your role models to describe that. Previously, we would have had a portfolio for you to use during your interview. That's not possible, given the difficulty with technology and overcomplicating it. So we will be asking you to use, just to use the information that you have at home to describe, your the work that you've done so far that makes it relevant for you to be a pediatrician of the future. And then the third section of the interview is around your ability to reflect. So we'll ask you to describe a clinical situation that either went well or not well, and then to think about why that happened, what you learned from it, and how you're going to take that learning forward, and how do you use your reflection in your daily practice. All of the other clinical components are more assessed in the MSRA in terms of clinical thinking. And then there are certain elements of the previous interview that are also assessed in the application form. So we've tried to assess things in the interview which are not accessible in the MSRA or the application form. We've got capacity to interview more candidates than we did last year. So we've got capacity to interview about 650 applicants, maybe 690. They're based across the country, but it's irrelevant because it will all be online anyway. So so that's going to be the interview process. Now, as I said, if the interview itself doesn't go ahead, then we will use the MSRA and the application form to do the ranking, but that would be, in my mind, suboptimal, because we want to give the candidates the maximum opportunity to really demonstrate their passion for pediatrics and why they want to do it in the future. So so that's a kind of brief run through where we are. I think maybe now would be a good time for me just to listen to questions and take some questions.
Thank you, Dr. Simon. We appreciate really your time and thank you for comprehensive talk. For the time being, I can't see any question. Guys, if you have any question, please write them down in the chat box, or you can put on your microphone and ask Dr. Simon directly.
And definitely use the RCPCH website. It's got all of the information on it. It's got 2 recent articles that myself and Emma Coombe wrote, who's the lead trainee for recruitment, working with me as the officer for recruitment at the RCPCH. So the question's only for ST1. I'm happy to take questions for ST3-4. If you want, I can give a brief update. It's pretty similar actually, but we'll be assessing slightly different things at ST3-4. So the process will be the same, but there's no MSRA for ST3-4. So the MSRA is really aimed at the F2 going into ST1 level. So the process for appointment ST3-4 will be the application form and the interview. And the application form, I think, is 40% and the interview is 60%. And in that interview, we will be doing communication, clinical thinking, and a kind of governance leadership type question. So that will be a half-an-hour interview. One of the problems with the interview process this year is that your entire interview will be with the same 2 interviewers for ST1 and for ST3-4. So, whereas in the past you were interviewed by 4 sets of different interviewers, which helped to give it more standardization, and this time it will be just the same interview panel interviewing you, just for ease of technology. So it's slightly different for ST3-4. So application form and interview.
Right, thank you. There's a question about the application. Which part of the application is more important in scoring to focus on for ST3 applicants?
So the number of points that are there for the application form and how we mark it are all on the RCPCH website. So what we've tried to do is to take away the bits where previously there used to be double marking to make it fairer. So we've reduced the weight that research and postgraduate degrees get and tried to make that into just one marking scheme, because previously someone could have got 4 marks for having had a PhD and another 4 marks for some publications. So we've tried to make it fairer and streamlined. But the actual scoring system for ST3-4 and the application form is all on the RCPCH website.
Okay, thank you. The other question about clinical thinking station. The question is how it is interactive. Is there any guidance given to the assessor?
So the assessors will have the questions and prompts. So they will make the same prompts to everybody. Obviously, it's difficult giving speaking to 2 interviewers, but via Teams is not the same as being in the same room as them in terms of getting that kind of feedback that you get from being in the same room as 2 other human beings. But we'll make it the best we can. But they will have prompts. What I would say is listen to the question, really listen to it and make sure you answer it, and answer as much of it as you possibly can in your first go, and then wait for prompts. It may well be, we've had some clinical thinking stations in the past where, so for instance, bacterial meningitis in a baby, and actually the interview for that station, which has got 10 minutes of time, but actually it only took 6 minutes for really good candidates to complete. So don't worry if you finish that station early, but I would say, really listen to the question, answer as much detail as you possibly can in the first go, listen to the prompts. And because of the technology, the interviewers will be very sympathetic, and they will try to nudge you back on track if you're getting off track.
Lovely, thank you very much. Just to emphasize, you mentioned for ST1 in the communication scenario, it will be the age of the children, it will be only from 6 to 16. Does this mean they don't have like a neonatal scenario or whatever?
So we've got no neonates and no safeguarding scenarios in ST1.
Okay.
The conditions, the actual main conditions are things that you would expect to see even if you hadn't done a pediatric job. So asthma, diabetes, sepsis, pneumonia. But the difficulty of that station is the communication. It's not really the medical knowledge of the situation.
Okay, fair enough. Thank you. We got 5 minutes now. I'll check if we have any more question. There is question, but really I couldn't get it well. Is the interview limited to these announced by RCPCH or could involve other part of e-portfolio?
I'm not sure if I understand that question.
Yeah, me too. I didn't understand it. I didn't get it well. Who put this question? If you can just write it again in more clear way.
But you don't have to be a member of the RCPCH to apply to pediatrics. Whereas before, when we could meet up in person, you could bring certain parts of your portfolio along with you. Now, because of technology, that's more difficult to do. So, but you don't need to just talk about pediatric topics in your interview. If you've not done a pediatric job, I remember speaking to one applicant a few years ago, and and I asked about her previous experience, and she said that she had deliberately not done pediatrics during foundation, because she knew that she was going to be a pediatrician and do pediatrics for the rest of her life. And she wanted to get as much experience in other fields as possible before she went into pediatrics. So I think that's not only very reasonable, it's very mature. So you don't need to just talk about pediatrics. You can talk about your learning from in adult areas, but it is then about looking at which parts of that that you can take and also use in pediatrics.
Right. I can't see any more question in the chat box.
So I hope that was useful.
Yeah, it's really useful. Thank you very much. We appreciate your time. Thank you for comprehensive and thorough talk. Thank you very much.
Anytime, and if you need me to come back again, just let me know.
Okay, thank you. It's a pleasure to have you today. Thank you very much.
Have a good day, everybody.
Okay, have a good day. Bye. We have more 3 minutes until we be ready for our next session. Then we can present our next speaker.
If Umberto is ready, we can go, and why not?
Yeah, I'm happy to start if everyone is.
Okay, so in our second session, we are honored also to have Dr. Umberto Piaggio. who is ST8 pediatric trainee with a special interest in neonatology. He is pediatric trainee in Sheffield Children's Hospital, and he is honorary teacher at the University of Sheffield. For the next 20 minutes, he will talk about clinical thinking. Dr. Umberto, you can start. I'll just give you a reminder when you have 5 minutes remaining.
Perfect. Thank you very much. Hi, everyone. I'm Umberto. I'm, as you can see from the screen and the presentation, a pediatric trainee. And I've done some clinical interviewing preparations, both for registrar, SHO, and consultant interviews. So I hope that the next 20 minutes will help you with your clinical reasoning scenarios on your interviews. Am I controlling the presentation? Yes. Okay, thank you. So I've got 3 aims for the presentation today, and the first one is to understand what is clinical reasoning and why is it actually on the interview process. It's important to know what they're expecting of you and give as good an answer as you can, depending on the question that you're being asked. And that really depends on knowing what they are actually asking you. They might phrase a question with a yes/no answer, but actually what they want to know is what the process of your thinking is and seeing whether or not you're a safe clinician. And like any interview, the more structured you are, the more confident you are in your answer, the better they're going to see you as a clinician. Next, please. So there are a couple of definitions I want to run past. The first one is clinical thinking, and that is basically a decision-making process that describes your clinical choices, whether to start antibiotics or not, whether to admit the child or not. But it really focuses just on the choices, and that's probably not going to give you the top marks on your interview session. Next, please. So what I want you to try and do on your interview is clinical reasoning. And that is because it is focusing on the process itself, on the problem-solving pathway that leads you to that decision-making process. It's looking at the whole clinical situation instead of just looking at how would you treat, let's say, asthma or meningitis. Any clinician up until this stage should be able to manage the medication. But what they want you to demonstrate is that you are thinking as well as a disease into what the child's surroundings might be, what the parent's situation might be, and try and organize all that with your team, with your team to make a good clinical management. Next, please. So within the clinical interviews, what they're asking is, with a simple question, trying to gauge your capacity for clinical knowledge, your judgment, your awareness of what might keep this child safe or unsafe, how you are going to be a potential team leader, or how do you work with your team, and evidence that throughout that whole process, you're using the good clinical practice skills as per GMC and RCPCH standards. Next, please. So my approach to things is going through examples. So what we're going to go through is a case of a wheezy child that presents to A&E. Next, please. So let's read through this together. And the question that your assessor might give you is, how are you going to manage this case? But let's talk through the actual presentation. This is a 6-year-old boy that comes to the acute pediatric unit referred by his GP. He has been coughing at night for the last 4 months, and it's mainly in winter, and he's currently very short of breath. You assess the child and find mild wheeze, shortness of breath. He looks tired, and his saturations are quite low. Then you overhear that the nurse is telling you that the mother also smells of smoke, and that's tobacco smoke, and that she comes in frequently to the hospital with another child who's this patient's sibling, who in turn suffers with severe asthma, has previous intensive care medication admission, and is not complying with her medication. So how would you manage this case? I'll give you a few seconds so that you can start thinking about how would you address this. And I'm giving you a clue on the image next to this scenario. Just apply your clinical knowledge, the information from the case to present a management plan. Okay, let's get to the next one, please. So in order to know how to answer, we need to go through what an ineffective answer might look like. And I say ineffective because it's not wrong. You're answering the question. But remember what I was telling you about, the panel members would want you to demonstrate how good you are, not how good a diagnostician you are, but how good a doctor and a physician you are. So this answer is very simple. This child clearly has asthma. I would give short-acting beta agonist on a regular basis and support his breathing with oxygen, give steroids, and once stable, we would arrange a follow-up in an asthma clinic, as they probably already know the family. Now, that is very simple. You're not going to be able to speak about the case for 20 minutes with the panel after that answer. And there are some other caveats that we need to address. Next one, please. So let's go through why this is an ineffective answer. So first of all, you have identified that this child might have asthma, but have you talked to us through the process itself? Why do you think this child has asthma? And at any point, have you measured whether this is mild asthma, an exacerbation, a non-exacerbation, or is this a life-threatening episode? You haven't demonstrated your clinical reasoning behind all these. Next, please. Then you have mentioned that you know how to manage asthma, but you haven't specified how regularly would you want to assess to do this. How are you going to reassess a patient and how often? You haven't considered, or at least mentioned, that you would consider other options. So for example, would this child need IV management? Have you thought about things like ipratropium bromide? And what steroids are you going to give? We can give prednisolone, and that's the usual things, but you can also give dexamethasone, and that would shorten the stay in the hospital. Sorry, wait a second. I'm in the meeting. Could you go with mommy, please? Yes? Sorry about that. And then we need to know if you can work effectively with your team at all the stages through your through this answer. You have mentioned I would arrange, I would give, I would speak. You haven't said about any interaction with anyone else in your team. And also, a very, very simple question at the registrar level: would this child be admitted to the hospital or not? So your management is good. You would treat asthma, but you're not treating the child. Next, please. And as we mentioned before, you have identified that the child needs a follow-up, but have you actually made sure that things are safe for the child in the meantime? You never mentioned anything about preventer medication or education so that this child is being treated at home adequately? How about going straight to an asthma clinic? Is that the best way forward, or would you think that the general pediatrician might be able to provide better care and try to minimize the input on tertiary centers? And lastly, how confident are you that the management at home is going to happen? This child's family is known to be non-compliant with medication and engagement with medical services. So it might be a good idea for you to have delve a little bit more on how you would have dealt with this. Next, please. So what are they actually asking you with this? They're asking you, do you know about asthma and how to stratify that into mild, moderate, severe, life-threatening? And do you know the treatment for each one of them? Next, please. They also need to know if you can get information from the case and apply that to your clinical knowledge. Make sure that you get the medical relevance, but also the surrounding information that is also relevant to treat the patient. Next, please. And also with your management, are you going to be a micromanager or a macro manager? Are you going to be that person that needs to do the cannula, needs to prepare the medication, needs to give the medication? Or are you going to be more efficient and ask your team members to support you and increase the level of quality of care for this child? Also, we need to make sure that you're engaging with the most important team member that you've got, and that's the family. They need to know what you're going to do, how you're going to do that, and why. Especially on someone like this family, that they are known to have some risk factors. If a mum smells like tobacco, that means that child is at risk of readmitting because of all the triggers. And they are also known to have life-threatening asthma on the family. They're also known to be non-compliant. We need to address and find out why those things are happening. Next, please. So this is a very long answer, but it's an effective one. The red bits are the parts that we have seen on the previous ineffective answer, and you can see that there's a lot of blue around there that just adds to the answer. So we'll read that through together. This child is presenting with symptoms of asthma. Looking at the length of his symptoms, his shortness of breath, tiredness, and saturations, he has severe life-threatening attack. I would declare the emergency, asking for a crash team, and would work my way through an ABCD clinical assessment. First, I would give oxygen via face mask to keep safe saturations of oxygen. I would then ask nurses to set up and give him combined short-acting beta agonists and ipratropium nebulizers, 1 dose every 20 minutes for an hour, and oral steroids. I would likely do an early IV access or ask my junior to do one, as there is a potential that this child might need escalation of care. I'd like to see a blood gas to check the pH, CO2 levels, and lactate. I would review the child regularly, update the crash team when they arrive in an SBAR fashion, and discuss further management options. This child is going to be admitted to the hospital, and we need a decision whether he could be in the ward or in a high dependency care. Next, please. And we carry on because we haven't addressed everything that they're asking on this question. So once the child is stable, I would speak with the mother, explaining the severity of the situation, what we have done, and what is likely to happen. I would take a detailed history to get better understanding of the whole situation and take the opportunity to do smoke cessation advice. I would clearly highlight that preventive medications and compliance are important, asking them if there's anything that we could do to help them ensure this doesn't happen. This happens in the future. I would update my consultant about the case and discuss follow-up plans. We will need input from asthma nurses, but likely he could be managed in the general pediatric clinic if he recovers quickly. Now, can everyone see the major differences between an ineffective answer that deals with a disease in its own and this answer that deals with a whole situation? And how would you explain why you took those decisions? Next, please. So why is this effective? Why this answer is going above and beyond the straightforward yes/no question? It is effective because you have given a structured, logical, evidence-based clinical management. But you have also demonstrated that you're able to work alongside a team and show leadership skills. You have demonstrated that you can see the whole picture. You can treat the child, not the illness, and that you're not afraid to discuss difficult subjects, for example, smoke cessation advice or medication compliance. Now, you will see throughout the whole course of today that there are different stations, let's say, for clinical skills, leadership skills, but that doesn't mean that throughout the other processes you won't tick boxes or increase your marking by demonstrating or mentioning those other skills. So don't forget to mention those. Next, please. So there are some caveats of giving a perfect answer. If you took a little bit of notes, reading that whole answer at a paced voice, that was roughly about 2-3 minutes of an answer, which is roughly what you should be aiming for. However, that means that for the next 18 minutes that the panel members will have you in that station, they will be asking you probably very tricky questions because you've really been thorough and given them a very good detailed answer. They would expect you to be an expert, at least know the BTS guidelines, so they will be asking you slightly more technical questions sometimes, and probably that's something that you want to avoid. So,
Dr. Umberto, you have 5 minutes remaining.
Yeah, so next, please. So you would be able to answer questions like, how do you know this is severe life-threatening asthma? Why would you need a crash call? Why would you need an escalation of care? Next, please. And other things that might be a little bit more technical, but you can structure your answer in a way that you can feed them information in a very simplified way at the same time of giving them hints that you already know the answers for whatever question they might be asking. So for example, by saying I would emphasize advice regarding smoke cessation, the obvious question that they're going to ask you is, what kind of advice would you give this mum? And with just hinting at that question, you are likely to be able to respond quite quickly and in a very structured way, saying asthma is a trigger for, smoking is a trigger for asthma. We want that to stop. I would speak with the GP and ask her to follow smoke cessation plan. I would give her a written plan for that to happen. Next, please. Another way to structure your answers is by using mnemonics. So I'm giving you 2 examples that might apply to clinical settings or decision-making processes, but STAR applies more for an episode of something that has happened. So for example, describe the situation, task, action, response, or reflection. And SPIES might apply a little bit more to a difficult situation. They might be asking you about a second question, let's say, if this child come in again, but this time mom is clearly intoxicated, how would you support that child? And SPIES might apply a little bit more to that situation. Next, please. So I've finished my presentation. I know that we're a little bit short of time next, but I'm happy to answer any questions if they've been on the chat.
Thank you very much for this incredible and impressive talking about clinical thinking, how to approach the station of clinical thinking. It's really helpful for all of us. Thank you very much.
No problem.
Just checking if there's any question coming to the chat box. It's all about nice talk, Umberto. Thank you very much.
I have a question.
If that's okay, Dr. Gowai, go ahead.
It's just a short question about when you answer the clinical thinking scenario questions. Is it okay just to give the whole answer continuously, as you just mentioned now, or give it a break, give 2-3 sentences, stop, look at their faces and see what their reactions are and then continue, or just keep on running, because if you run the same tone, I just feel it's going to feel more mechanical rather than, I don't know.
It really depends on your own experience and your own level of confidence. There are different kinds of candidates, and usually what you would have is a very nervous candidate and constantly trying to see the faces of the panel members might give you even more nerves, or it could calm you down. It depends on your own personality. When you're talking about giving a full lengthy answer, what you want to try to do is calm yourself down throughout the process and give them a very good answer that you can probably follow up with the questions. However, I completely agree that some candidates out there might feel more confident just tailoring things according to the responses of the panel members, and stopping after a couple of sentences to do that also gives you time to think and reassess what you've actually told the panel. Just remember that they might not be engaging with full eye contact all the time. They might be making notes or ticking boxes. So don't take it personally if you raise your eyes to the panel and no one's looking back at you.
Thank you.
Hello, everyone. I have a questions, if you allow me.
Yes.
Okay, I was thinking in the same way when you told us the scenario, and after that you told us, okay, think about it. I just thought about, okay, this is acute management, chronic management, and then later on, the social address, the social issue, and everything. Can I present it in the same way?
Present in the same way as in use the structure of I would do this acutely, then on the chronic management I would do this, and from a social management do the other bits. Have I understood the question?
Yes, I mean, in acute management, I will do all the emergency you said. Then after admission to a child, I will address the chronic issue of asthma. I will also address the GB visit. You have asthma clinic. I didn't thought about asthma clinic actually, but I thought about the GB visit, health visitor, smoking, support to the family, something like that in the same lines.
Yeah, so the thing is you have to have a structure. It might be a timeline approach, which is what I used here. It might be a subheading approach like you've alluded to, just seeing the acute management, the chronic one, and the later on. Or it might just be dealing with asthma as a general thing. I would probably in the acute phase stabilize the child, and I'll talk about that later. However, usually what I would find it more useful is for people to be compliant with their medication and then start with the general management of asthma at home, follow-up clinics, then go on to the chronic management, and then finally say, if this child presents like this in this case, then what I would do is treat with the BTS guidelines management.
Okay.
There's no one good answer, and it really depends on whether you can demonstrate the skills that they're asking you to display.
Okay, thank you very much. I'm afraid I would stop you here just for the sake of the time, but it was really nice to hear from you. Thank you very much. We'll move now to the next speaker. I'll pass the microphone to my colleague Puran to present her next speaker. Thank you very much.
No, thank you for the opportunity. Bye.
Thank you. Thank you, Dr. Umberto. Thank you, Iman. Good morning, all. Really well done for the organizers, and a huge thank you to all the speakers today, and good luck to the candidates. It's an honor to me to present or to introduce the next speaker, Dr. Rachael Mitchell. Dr. Rachael is a pediatric emergency medicine consultant at King's College Hospital in London. Dr. Rachael will give a 25-minute talk about leadership skills and communication. I wouldn't interrupt that, only 5 minutes toward the end of this speech. I will set a reminder, and by the end of the speaking, we can have a 2 to 3 minutes chat, and I will read your questions. So please, if you have any question, post them down in the chat box. We are ready for you, Dr. Rachael. Thank you.
Great. Hello, can everyone hear me?
Yeah.
Brilliant. Okay. So thank you for inviting me here today. I as you've just heard, I'm a paediatric emergency medicine consultant at King's, and I help out doing various interviews. So hopefully can give you some top tips. As far as I know, I just want to clarify this, most of you are applying either for ST3 or ST4. And you will be, hopefully, COVID allowing, having some virtual interviews in the coming weeks. Great. So I've been asked to talk to you today about your communication scenario. I don't know if you can put the slides up so people can see them, because at the moment I can just see all of the slides. But I can talk if you want to do it like this, that's fine. So my second slide, which you can probably see here, is talking about the communication scenario. So I think the first thing to say really about communication is that there is nothing really different to communication to what you do on a day-to-day basis at work. And all that will be asked of you is in relation to your everyday jobs. So it's not you having to learn anything new. It's not you having to think differently to how you would normally think. Obviously you're being assessed, and so it will feel different. But if I can get you to think of one thing today to take away from it, it would be that you just need to be thinking in the same way that you think at work. Is it possible to put this on the slideshow view, please? Maybe not. No, okay. I will just do it like this. Oh, maybe. No. That's the wrong talk. Sorry. So while you're getting the right slides up, maybe I will just chat a little bit about the scenario. So, as I said, thinking in how you think in your everyday work, talking to children, to young adults, and to their parents. So, if we could put up the second slide, please. Next slide. Brilliant. Maybe. Almost there. So while the slides are getting put up, hopefully all of you have had a look on the Royal College website. There's a really useful document there which breaks down exactly how the interview is going to be carried out. And so you've got four stations, as I'm sure you know, and one of them is the communications station. Perfect, thank you. Yeah, if you stop on that slide, that's great. So on the communication scenario, it's worth 40 marks out of a possible of 120. So if you just think about that for a second, that is telling you that it's worth a third of your total marks for the whole scenario. So actually this is a really important scenario, but one that you can do really well in by just thinking about some basics. What they want you to do is they're going to assess your ability to interact with, can you go back a slide, please? Thank you. With patients, parents, and carers. You'll be given the scenario to read 4 minutes before starting your virtual interview. And then you'll be asked to explain either a clinical condition or reasons for a particular intervention. And I guess that's worth thinking about because there are different things that you may be asked. The guidance other than that is a little vague. So there's nothing else that comes up that they tell you. But actually, I think thinking about just that little bit of information there can give you, can hopefully give you some really good top tips. So next slide, please. So in that, you've been told you've got 4 minutes to prepare. And that is actually really, really important time. So I would really encourage you to use that time wisely. It may be at the start of your circuit, it may be during it. And so if it is during it and the station before it hasn't gone well, do take 30 seconds to clear your head and then move forward. But I would really encourage you not to spend all your time thinking about the previous scenario, because you've got 4 minutes to think about this scenario, and actually you can do a lot of preparation in it. So what are you going to prepare in that time? Because you're going to be given a little clinical snippet, and you're going to need to think about what you're going to cover. You will be able to make some notes, and in a real scenario you could obviously take those notes in with you. Because this is virtual, you'll be able to have the notes alongside you. You won't be able to look anything up, but you because we are emulating what would be a real in-person types interview. But actually it's not about, as I'll talk about in a minute, it's not about looking up and things being factually very very detailed. It's more about, remember, this is about communication. Okay, so what I would really get you to think about here is what you want to communicate in that time, how you're going to communicate, and a few of the communication top tips. Okay, so don't just sit there and think about nerves, however hard or easy it is for me to say that. Really do try and use this time, because actually you've been given it. You haven't got it for the other scenarios, so it's important you use it appropriately. Next slide, please. So I thought for a minute we might think about a few possible scenarios. So as I said, it could be that you're asked to explain a new condition. It could be that you're asked about reasons for intervention. And so again, none of these are really are going to be difficult scenarios clinically. They should all be things that you've done before, that you do at work all the time. So the kind of ones I've thought about for explaining a new condition would be a child with a new diagnosis of diabetes, explaining a febrile seizure, possibly a new diagnosis of a leukemia, although that probably is a bit trickier, and explaining a nephrotic syndrome. So these are just a few that I've thought about, I know have come up before. There definitely are others that could come up, but they would be the ones that if you were thinking about things, that I would maybe think about. And so you could start off by having a little think about how you might approach those. If you're thinking about reasons for interventions, then I guess some of the common things that we do would be thinking about consenting a family for a general anaesthetic for a scan, cannulating a child to give out antibiotics, particularly if it probably won't be the first time they've needed a cannula, so perhaps a family that don't want a cannula in a child. Doing a lumbar puncturing in a neonate. Now that's a very common scenario that we see, isn't it? Doing a intraosseous insertion in an emergency. the slides have just gone, sorry. And then the other couple of things that they've said could possibly happen would be that you might be asked to talk about why a child may be transferred, so to a neighbouring intensive care unit or to a tertiary centre for further investigations. So this is by no means an exhaustive list, but what it hopefully does is just give you a few ideas of things you can think about in your preparations. Next slide, please. So important to think about who you're talking to. So it clearly states that you may need to talk to a parent, you may need to talk to a child or an adolescent. And actually where you're going to pitch this really depends on what your audience is. So clearly your explanation of diabetes to an 8-year-old is going to be very different to your explanation of diabetes to a mum or a dad. I think it would probably be quite mean to give you an 8-year-old. I think a kind of young adult, so 14, 15-year-old would be reasonable. But even then, the way that you talk to that child is going to be different to how you talk to a parent. So just make sure when you're reading the scenario that you've thought about that. Next slide, please. And what will you be assessed upon? So I think one of the things that people tend to fall down upon is that they get really caught up in thinking about the clinical context of things, and thinking about purely delivering clinical information. And yes, that is an important part. If you see here, it's one of my 5 points here. But actually, what you need to be thinking about is that this is a communication scenario. And so yes, the information you deliver needs to be factually correct, but actually what the assessors are going to be looking for is your communication with the patient or the family, as opposed to purely the clinical content. So in any clinical scenario, when you talk to a family, you will go in and introduce yourself, and that should be no different in this scenario. So a nice introduction, putting the family or the child at ease, is really important. And then as you do that, you need to give them some signposting about what your talk is going to be about. So don't just say, I'm Dr. X, I'm going to talk about, I'm Dr. X, you've got diabetes, as I'm sure you wouldn't do that in real life. You would probably find out what they know about a scenario, about what's happened so far, and really kind of work out where you're pitching this, what their previous level of knowledge is. If you're talking about a new diagnosis of diabetes and they've not actually been told they've got this yet, then actually that's in the realms of breaking bad news. And so do you need to be seeing if there's anybody else that'd like to be present? If you've got a bleep on you, you might make sure the examiners know that perhaps this is a sensitive conversation, so you might hand your bleep to somebody else to look after. So in the same way that you would be thinking in real life about how best to deliver some difficult clinical information, then this is all really important stuff that you need to be thinking about here. As I said, clinical content, very important, yes. So don't deliver incorrect information, but actually you should be guided on the content in part by what by how the patient or the family is responding to you. And a lot of that it comes from the non-verbal cues, which I'll talk about shortly. But they are the things really that make or break a communication scenario. I'll talk about that a bit more in a minute. And finally, when you've finished, it's really important that you summarize the information that you've given them. You ask them if they've got any questions, and you also then kind of give them some signposting, either to some more information they could go to, or say you'll come back later and talk to them. But don't just leave them hanging. Don't just say thank you very much and go, okay? And I think it's really important that as you would in the real world, think about how you close the scenario in a way that makes them feel that they've got somewhere to come back to. One thing just on the introduction that we talked about, just going back a second, when you introduce yourself, I think gone are the days in certainly where we're all introducing ourselves as Dr. So-and-so. Actually, I think, especially if you're talking to a child, being able to introduce yourself with your first name is really nice. And I'm sure many of you do that in your clinical practice already. But certainly that would be something that I would be really pleased to hear if I was an examiner. Next slide, please. Oh, so that's not come out very well. Sorry about that. But non-verbal cues is what I was going to talk about, not non-verbal cues. Okay, so when you are delivering any kind of clinical information in person, then yes, the words that you use are important, but even more important than that, often, are the things that you do without even meaning to. And if you speak to parents and relatives after you've given information or after you've delivered bad news, often they won't remember the words, they'll remember your manner and how you were to them. And that is incredibly important in the communication scenario. One thing to say is that when you're marked for this, the actor will be asked for their views and also give you a score as part of your score. And so, yes, it's important that you impress the examiner with your clinical knowledge, as I've said, but how you communicate with an actor, particularly in terms of these things, is really important. So what kind of things do I mean? Well, it's about using silence. So you deliver some information and you let it sink in. You see if they've got any questions. And I guess from that perspective, you're doing some active listening. So when they ask questions, or when you say, or when you ask them what they understand already about a topic, you do actually answer their questions. You do actually listen to what they're saying. So you're not dead set on what you're meant to be delivering. You're flexible, and you alter your clinical. You alter your what you're talking about depending on what the audience wants. You treat them with respect, and that sounds like an obvious thing to say, but actually that is incredibly important. So sometimes the scenario, so for instance, if you had a scenario about giving antibiotics so giving further doses of IV antibiotics to a parent who really didn't want another cannula, then actually being authoritative about it and saying, no, we're doing this because it's what your child needs, is not treating a family with respect. You need to be listening to what they're saying and trying to understand, and that will come across in your scenario. Generally, the actors are given instructions that say, if the candidate convinces you well enough, then you will agree. So it's very unlikely that by the end of a scenario, you should still have a parent saying no, so long as you've spoke well to them and done these things. Open body language. So by that, I mean making sure you're not sitting with your arms crossed, that you're perhaps doing open gestures with your hands. Granted, it's much more difficult virtually, but I'm sure many of you do these anyway in your normal working practice. Empathy. So actually, are you really thinking what it's like to be that parent? So if this is the fifth day that they've been in hospital with IV antibiotics, are they actually really shattered because they're really tired and they've not had any sleep, and because of COVID nobody else can visit, and actually they just want to go home and they don't really understand about the risk to their child? Actually just taking a minute and saying, this must be really hard, I'm really sorry, is there anything else I can do? Can I go and get you a cup of tea when this is over? Sounds really simple, and probably in real life that's maybe what you do, but this should be no different. And then picking up cues. So it kind of like I've already covered, but is there something that they're particularly scared about? So for instance, in the scenario of a child having to be transferred elsewhere, are they worried that they'll catch COVID in another hospital? The scenario where they've got a new diagnosis of diabetes, did they have a grandparent perhaps who had a type 2 diabetes who then died? So are they thinking about other things? Is there something particularly that's on their mind that they haven't really articulated to you? So I think these are really, really important things that you need to think about when you're delivering your scenario. Next slide, please. And obviously, it won't have eluded you that this is virtual. So a lot of this is going to be different. And it's just worth thinking about how you're going to get across some of this, some of these nonverbal things virtually. I'm not saying it's easy at all. Silly things like looking at the camera as opposed to yourself on the screen. And if you are going to use hand gestures, trying to do that. You might normally draw diagrams perhaps when you're explaining something. That will be more difficult. So you might just want to practice beforehand, perhaps with a friend, about how that kind of thing might work. Next slide, please. And I guess just going back to the beginning, why are we doing this? What are the assessors wanting to see? They want you to be safe. They want to make sure you can communicate with patients and relatives and that you can empathise. And more importantly, they're asking the question, are you a safe pair of hands in the middle of the night? So if you're the registrar on shift, are they going to be happy to leave you to get on with things in the middle of the night, or are they going to have to be phoning you every hour? And if I'm totally honest, as a consultant, that's the thing I would want to make sure, that I was going to be happy that you were going to be in charge at night. And of course, I'd be on the end of the phone to never worry that your consultant doesn't want to be called, but it's just about them being confident in you and your abilities. And communication is the first thing that we see about people, so it's incredibly important in that sense. Next slide, please. So I thought we'd pause there for see if anyone has any questions. I've got a couple of scenarios that I thought we could just talk through if there's time, but if not, I can just show you the scenarios and you can perhaps have a go as practice with other people afterwards. So I don't know if anyone's got any questions at the moment.
Well, still we have 5 minutes, Dr. Rachael, for your talk, and
Okay,
we
great.
will allow 2 to 3 minutes by the end of your talk for questions and discussions. So I think you can go ahead with the scenarios.
Okay, so I just wondered if anyone on the chat's got any questions at the moment. Please put them through, otherwise we can go to the next scenario.
Yeah, nothing at the minute in the
Okay.
chat.
So
Okay.
Next slide, please. So this is the first scenario. So your SHO comes to you about admitting a 5-week-old baby who has a fever at 2 in the morning. As part of the workup, the SHO wants to do a lumbar puncture, but reports the parents have refused. You need to talk to the parents. So that is the kind of scenario you're going to get. You're then going to have 4 minutes to think about how you might approach this. And I guess I know it's tricky on the chat, but I guess I wonder what kind of things you might be jotting down in your 4 minutes. I wonder if I just give you 30 seconds. I wonder if everybody could write a couple of things in the chat that they might want to, that they'd be writing down, and I can have a little look. So why it's important to do LP? Yep, definitely. Yes. Yeah. So I think what's really nice that's coming out here is why they're refusing. Exactly. So I don't know, because I don't know about you, but I've often found that I've been told this scenario, and when I go to it, it's actually that the parents don't really understand why they need an LP and why it's important. And I think that's the most important thing here. What is it about the LP that the parents are worried about? So I quite like what Salma has said here. So I would introduce myself, ask what they know so far about the baby, why the LP is important and why they refuse. Good. And so obviously as part of a consent process, you're going to talk about the LP and the risks, but actually moreover at this point, you need to try and get the parents on board. And there are certain things you need to tell the parents. So what the lumbar puncture involves and what the risks are. But actually, as everybody has said in the chat here, it's important to try and understand the parents' point of view, find out what they already understand, and try and convince them. Somebody's put here about putting the names of the babies and parents, and I think that's a really nice idea. So some parents will want to be called by their first name. Some people would like to be called mum or dad. Some people would like to be called Mr. or Mrs. And so it's quite personal. So I think that's a really nice thing to ask. And similarly, we're very bad, aren't we, as paediatricians, at calling everybody baby. So actually, if you've got a 5-week-old baby, you're so proud of that baby. You want people to be calling that baby their name. So actually finding out baby's name is a really nice touch as well. So I'm really pleased here that you've got the essence of this, that yes, this is about you delivering information about doing a lumbar puncture, but more than that, it's about trying to work out why these parents are refusing and how you can convince them. Okay, and second scenario. So your SHO has seen a 2-year-old presenting with a puffy face and swollen hands, who has 3+ of protein in the urine, an albumin of 23 on bloods. The baby's otherwise well with normal blood pressure and bloods are otherwise normal. You're asked to speak to the parents about the diagnosis and the next steps. So hopefully with that clinical triad of edema, proteinuria and a low albumin, you can see that we've got a case of nephrotic syndrome. Hopefully from this you've seen that the blood pressure is normal, the other bloods are normal, and so at the moment this seems to be an uncomplicated nephrotic syndrome. So again, I wondered if you could just jot down a couple of thoughts about what you might be talking to the parents about. You're asked here to talk to them about the diagnosis and the next steps. So you need to make sure you cover both of those, but clearly this is going to be a big deal for these parents. So just 30 seconds to write down a couple of things here that you might cover.
Dr. Rachael, I have to say that we have only 1 minute left for
Oh,
this session.
I'm sorry. Okay.
No, it's all right.
Maybe I won't.
Yeah, go.
I won't get you to write the stuff down then. I guess what I just wanted to make sure you understood here was that you need to talk to them a little bit about nephrotic syndrome in very basic terms, but actually they are going to be worried that something terrible is wrong with the kidneys. And so trying to reassure them and talk about how they're going to be followed up is really important. Lots of time for questions, lots of silence, and it would be lovely to be able to draw a diagram here, wouldn't it? But virtually that may not work. So you might need to think about how you explain it better. So that's I think I've got one more slide which just asks you for any questions. I'm more than happy for people to contact me if they've got any questions separately. I hope that was useful. I think the real thing I want to just get over to you though is that this communication scenario is about you putting patients at ease and talking as you would normally talk in your everyday practice. And so hopefully it's a way of you getting lots of lovely marks in the interview. Thank you.
Thank you, Dr. Rachael. We have a question down in the chat. Well, it was actually a comment from Azza about ask what the parents know about the condition, explain nephrotic syndrome in a simple way, avoiding jargon words. And still we have like 2 minutes. If anybody have any question or if Dr. Rachael have any thing to add.
I guess just one thing I would say about jargon, I think that was a really good point. So we're very bad, aren't we, as doctors, at using acronyms and using jargon, especially if we're talking to young adults or children. We mustn't do that at all. And so, making sure that everything you talk about is said in a really simple way is really important.
Any more questions? I personally found that session very useful and with great tips in communication scenario. Thank you very much, Dr. Rachael, for your time. Thank you for contribution.
No worries. Good luck, everybody. Thank you.
Yeah, thank you very much. We are ready for the next session.
Are we going to have a 5-minute break or are we going to start immediately?
Yes, I think we can take a 5-minute break or so and come back.
Thank you. I think if everyone is back, we can start.
Just a second, Omar. They are just trying to fire the presentation.
All right.
Omar, can you see the presentation?
Yes, I can see it. Yeah.
Is it full screen?
Full screen, yeah.
Okay. Can everybody see the presentation as full screen? If you can just type in the chat, yes, no? I don't know if Dr. Sara is ready. We can go ahead. Maybe Omar can present her. Is Dr. Sara ready?
Good morning. Yes, I'm ready.
Okay. Okay. Hi. Good morning and good afternoon, everyone. I think this is a topic most of overseas want to hear about is clinical governance, and it's our pleasure to have Dr. Sara Abdelgalil. She's a pediatric consultant and she's an associate professor here in NHS. And without further ado, thanks, Dr. Sara, for sacrificing your weekend, and welcome.
Assalamu alaikum and good morning. I'm on call, so it is, I'll try to finish on time. And thank you very much for the team and welcome. I understand that this is targeting those who are applying ST3, ST4 and above, if I'm right. On this session, we'll try to cover clinical governance, but obviously that will include talking about quality improvement and patient safety, and as well highlighting some points about leadership. Next slide, please. I would like to reassure you all that when we talk about pediatric quality improvement and patient safety, it is something that you have been practicing and clinical governance from your previous experience. So don't feel nervous that you are, for example, you've not been in the UK or not practicing for a long time. And that's from practical course that now is we established in the UK and in Sudan from the UK. And actually during that course, all of the ideas were spot on, as we all aim to provide an excellent care. It's an honor that this course has now been included or will be included in the training for pediatric registrars in Sudan. The next slide, please. Next slide, please. Yeah. So I would like you first to feel confident and congratulate you that you came along, distance, and you have achieved a lot so far, and make use of all the experience that you have developed as a medical student or as a trainee in Sudan, UK, or anywhere else. And or whether you have any other degree or experience, even if it's voluntary or extracurricular that is related to pediatrics. And that's mainly when you are coming to talk about why you chose to become a pediatrician. And clinical governance, quality and safety and leadership actually should or can be utilized in all stations, but in particular the station when you're talking about why you chose this career, as well as the clinical governance station. Next slide, please. So you have been shortlisted to come for this interview. So you are eligible. So that as well as a bonus. You have to know how to self-market yourself, but don't overdo it. What the assessors are looking for is a competent pediatrician. So you're not anymore applying for a generic post. It is specific for pediatrics, and that you promote safety and high quality care. Most of you, maybe not everybody, is a member of the Royal College of Pediatrics and Child Health by now. And if you look at the main essence of the Royal College of Pediatrics, it's about quality, about medicine for children, and about child safeguarding and protection. So these are important areas that you will be expected to know very well, and even to highlight them or refer to them. And medicines for children is an important part when we talk about clinical governance, about safety and quality of care, because obviously there's a lot of medicines that are not licensed for children. We use weight, we use height, surface area. There are a lot of drug errors that can take place, especially if you're talking about neonates or pediatric intensive care or retrieval team, and as well about the awareness of parents and children about medication and safety, apart from the deliberate self-harm of using medicine in mental health. So medicine for children is an area that I would advise you look into, and you have a few examples that will help you in your scenarios. Next slide, please. So what should you focus on and what others assessors will be focusing on? As I said, and as the other speakers have mentioned, is to feel that you're familiar with the system. But as I said, you don't have to panic if you have not worked in the UK, but you have worked in other countries, because at the end, the systems, you will find that there will be similarities. But even if you're not very familiar with the system, you can highlight that at the end, but the process and the main concepts should be the same on approaching or managing children and young people. And it's very important as well to mention at this stage that it is not only about children, it's about young people, and that you understand that concept and it's part of your assessment. Safety and quality, which part of it is about your knowledge and about your skills, but as well about the way you address each station. Communication, you had the teaching previously, and mainly it's about the verbal communication, but obviously it includes the written communication, which is about letters or writing some information to the family or to the children. Although you're not practicing that, but you can add this at the end of your station by saying, and obviously you will get a letter that will summarize our consultation. But I would like to highlight here that the virtual skills now are developing because of the COVID-19 and the telemedicine, and this is something as well to be aware of. What people are looking for is that you will be a junior colleague, a good team player, a pediatrician. And this is something that actually you can utilize during your consultation or during your virtual assessment. On the right side, these are the main safety, quality, assurance, and clinical governance areas. But I would like you to concentrate on two: the pediatric early warning score, the PEW score, and situation awareness for everyone. So you should by now be familiar with the early warning score. What does it mean? When to use it? What its benefits? What are its pitfalls? And how are you utilizing it? As well, situation awareness for everyone. And I will come to talk about this in this talk. Next slide, please. So the Royal College of Pediatrics and Child Health, it's very important for everybody to know that they have been leading in quality improvement and patient safety. So they are very proud of it. And therefore, most of the assessors will be. And there are 6 domains for quality. There was a training course, and now that's expanding. And the 6 domains for quality is that you are safe, effective, person-centered. You're thinking about the child, the young person, the family. Timely may not, that can be mentioned during when you are talking about a scenario. Efficient, that's about cost effective, and now during the COVID-19 there are plenty of examples. And equitable is very as well important, as we are aware with COVID-19 there has been a lot of issues about equity, diversity, and inclusion. So if there is any hint within the scenario about that, you have to highlight that you are aware and understanding, and you will apply equitable care for all patients, and if they require a translator, if you need to look into their cultural background, and therefore this will be a bonus in your assessment. Next slide, please. So when we talk about the concept of governance, and allow me just in 2 slides to zoom out from the exam and talk about the concept of governance. Now, as you are applying for a senior trainee post, your expectation, the expectation that you will be understanding what is governance, what is clinical governance, and as well you understand that there is a organization governance or the trust boards. So I will just highlight some of these points. Next slide, please. So if you look at the generic meaning of governance, and some people will think, oh, governance means the power, means the president of the country, means Boris Johnson. But in a simple term, governance is how a group will organize themselves to make decisions. And for these decisions to be right and effective, there has to be a responsive, innovative, inclusive leadership. So you need a leader that understands what's happening and respond and flexible to the surrounding, use new methods and include everybody. And you're doing this every day in your shifts, whether it's daytime, but in particular at the night shift. And we will come and talk about that. In the next slide, please. So the National Health Services, and as well, this is a concept that you have to understand very well, that it is built on social justice and social services. And in a broader sense, the National Health Service is like an institution or an environment. It is a place where citizen and stakeholder will interact with each other to provide public services and utilize public resources. So when you're coming to work in the NHS, you are a public servant, if you use the term, and you are using public resources. So you have to provide the care that for the citizens, for your patient, they are satisfied with, and they feel that they are part of it and they are involved in it. And this is important when you come to talk about the involvement of the patients and the family in the scenario. Next slide, please. So generally, when we talk about NHS and trust borders, there is so trust boards are about who's responsible. So who is the named doctor for safeguarding, for example, who is the clinical governance lead, who is the guidelines and audit lead. So these are responsibilities that are important. There are programs and standards and recommendations, and there is an assessment, whether that's internally or whether that's CQC externally, to assure quality and continue on quality improvement. And there is always risk assessment and a risk register. Again, I'll refer back to the COVID-19, that there will be a risk assessment and there will be a mitigation to prevent risk. So always you have to talk about preventing risk. And if not, even if it happens, it should cause no harm. So reduce its effect. And this is one of the important aspects that we are going to talk about. Next slide, please. Next slide, please. I don't know whether you can you hear me very well? Thank you. So during this assessment, what is expected that you demonstrate your awareness and your understanding, as well that you are practicing clinical governance and you are applying it and promoting it. And that's very important. In the next slide, we are going to talk about clinical governance, the presentation. In the next slide, please. This definition, I think you know it now by heart. If anybody is not aware of the definition of clinical governance, please get in touch with me. I'm happy to explain it and give some tips. But most of those who have sat for the PLAB or have done an exams are already aware of the definition. But now you are at the stage, you are not going just to repeat or rehearse the definition in front of the assessor. No, you have to show how it works and what does it mean. And it's very simple. It's doing the right thing at the right time by the right person. This is much clearer and more practical. So what you want to demonstrate that you are aware of clinical governance, of what does it mean, and how would you apply that. And it's part of good medical practice in the GMC as well. Next slide, please. So what are the 7 pillars of clinical governance? And here you can see about 6 of them. So we'll go to, after I finish, then we'll talk about number 7. So what I would suggest when you are preparing for your exam is to look at the pillars for clinical governance and to have 2 or 3 examples for each. As well, I would like to remind you that any of these examples will be applied for most of these areas. So if you, for example, take there was an incident reported about a drug error, that the dose was prescribed wrongly, or it was prescribed right but it was there was a problem in administration. So there was a risk, there was an incident reported, that's number one. So this is number one in clinical governance, incident reporting, DATIX. Then this was investigated, and the risk assessment came out that there is an issue about the prescribing, about the drug cardiacs, about the calculation, about the weight. So there was a recommendation. So a clinical audit was planned, looking at that the standard will be 100%, no error in prescribing, looking at how many errors happened in the last 6 months, what was these errors. Then there was recommendation. So there was a protocol about drug prescribing. There was a plan to include it in the education and training and induction, as well as using the advice from the Royal College, because there is a video about prescribing. And then after 6 months, there was another audit, or there was a quality improvement project, and looking at the drug cardiacs every week, and assessing whether there is a pediatric pharmacist assessing the drug cardiacs and reviewing them, and how many errors were identified, and who was a prescriber, or what was the issue with the errors. And looking at the clinical effectiveness will be, you are aware about drug errors, you have done your training, you know how to use the electronic prescribing system or software. You have been trained in the mandatory, by the mandatory teaching or mandatory training before starting this job. And therefore, so you can take one example, and in this example, you can apply all of these pillars. And as you must probably heard me talking about quality improvement, as quality improvement at the moment considered as important as clinical audit, and therefore we need to understand about clinical audit and quality improvement projects. In the next slide, we'll talk about the 7th pillar, which is about the information governance or information management, and about how it is important about documentation, about as well confidentiality. And one of the example, DATIX or incidents, is dropping the handover sort of sheet in the restaurant while you're getting your food, and then someone picked from the public the handover sheet and found some scribbles, names, or hospital numbers. And obviously this is something that has to be investigated. Yeah, okay. So coming to the SAFE principle, and this is very important if you review it in the Royal College of Pediatrics and Child Health, and it will help you actually in the virtual scenarios. If you go back. Yeah, this one, thank you. In the SAFE principles, which is situation awareness for everyone, it talks about the clinical governance and about the quality improvement and about safety. So it is, if we take the common example about being the registrar at night, that you are the leader, and you have your team, and you will assess the situation. So you are coming, and it's a Friday evening, it will be very busy, and you have taken the handover. So the first part will be handover, and you have assessed the risk, who is sick and who will need your first attention, who's working with you. Is it a foundation doctor? Is it a pediatric trainee? Is it a GP trainee? So how much duties and responsibilities you can give to your SHO. The next will be what's happening within your other team members, which are the nursing staff. Are they full capacity? Is there shortage? Do you have an issue on the ward with a mental health patient that needs one-to-one? And what is the situation in A&E? Do they need your help? So you have done the handover, the proper, effective handover using SPAM, and you have done a huddle, and you know what's happening in your department, and you know what are the duties. and you are the leader, and you will determine what you can achieve and when will you need help, and when would you like to call your senior for advice. There are other issues that are very important and will help you, is about identifying a deteriorating child. So yeah, it's important to identify a sick child from your immediate assessment, but you may have some children that there are possibility that they may deteriorate during their stay, and therefore highlighting these patients and making sure that you review them every 4 hours or every 3 hours or every 2 hours, whatever plans you have, and using not only the early warning score. So there may be some question or some hints about what if the pediatric early warning score was a 0 for a patient, but you felt that this patient actually may deteriorate. What I'm trying to say that the pediatric early warning score on its own is not enough. It's about the clinical judgment and the clinical thinking, and as well about the experience and the prediction that this patient may deteriorate. So you have to utilize or use the information that you have within your clinical capacity. Next slide, please. So I would like here, if possible, I don't know whether I have time or not, to have 30 seconds to think about practical examples that you have. What guidelines have you been involved in, or you have protocols? What updates have you provided to your team so you can use this? What safety alerts were important in changing your practice? Have you been involved in an incident as you're reporting the incidents or part of an incident, and then you learned from it? Have you been involved as part of a complaint and there was transparency and openness and apology after an assessment of the complaint? Thinking about your mandatory training, and you are applying that because that's part of the clinical governance, in particular the infection and protection sort of training about information governance. Prescribing is an important aspect, so think about examples that can help you. Documentation and communication, I think we have covered that part. And the referral pathway and the triage over the phone or online. This is an important aspect now, as a lot of work is taking place online. So it's important, if you have been involved in any of these areas, to use practical examples. And you can write that on the chat for later for me, just to have a look and comment if you wish. Next slide, please. So going ahead, and during the COVID-19 and the last year, there are certain areas that can come in your assessment about telemedicine and telehealth, about patients with special or they have complex needs, and how would you care for them during the COVID-19 in a scenario. We talked about the Pew score, its limitation and its use. When you're talking about teaching, and it's part of the clinical governance or learning or continuous personal development, try to use as much as you can of variety of ways that you are learning and you are delivering as well knowledge and skills. Not only departmental, for example, teaching, but use different methods. Social media is very important. And if you have been involved, for example, in arranging this sort of training, so show that you are using different varieties. Now, safeguarding in children, although there will be maybe no scenario, but it's important as well to be aware, because if anything in the scenario may require that, so that you are trained, you know who to talk to, designated team for safeguarding, as well as mental health and camps, especially if there are any suggestion that there may be need for further assessment about mental health. So you have to be holistic in your approach, because that's part of sort of being effective pediatrician. Next slide, please. So there is a lot of interest, in the last few years about communication, about openness, about explaining errors, being very open about it, investigating it, and apologizing and making the patient and the family aware of the error and what does it mean short term, what does it mean long term, what have you learned as a team, and what changes have been made. And if I just give a very simple example, if we have a child that has been referred by the GP because the GP was concerned about the bruise, but the GP did not explain to the family that they're coming for safeguarding assessment, the family then has to be subjected to a lot of investigation, social services. Everything came back negative and the child went home, but they complained that they were not aware about this referral and the journey. So as a pediatrician, you are part of the journey. You have accepted the referral from the GP and you have to check that the family are aware of their referral. You have to apologize if they were not. I should have explained from the beginning about it. And the changes that have been applied is there is a pathway for referral between GPs and our team. And in the future, there is a check list that families are aware about. They're coming for safeguarding assessment, obviously, unless there's other issues that.
5 minutes left. Sorry, Dr. Sara.
No, that's okay. So next slide, please. So what is unique about pediatrics and child health? And that's for you when you want to talk as your career and bringing clinical governance. There is a lot of issues that you should be using and be aware of inside the hospital and outside the hospital, and that's about development, growth, food security, malnutrition, issues about pediatric staffing and rota, or shortage of staff, being aware of the COVID-19 and the effect that has caused about patient not approaching health services, and that has led that non-COVID effect on children has increased. Next slide, please. As well, there is an important concept about why children die in the UK. It's 6 years now old, but it's very important if you are going to talk about your interest in one of the specialties. So we can look at some of these figures and say that still there is a need in this area for more doctors, or I'm interested because still children are dying from so and so. Next slide, please. So think that about yourself as being the leader, whether you are an SHO on the ward or the registrar at night. Use the SAFE framework because that will help you. Talk about the patient journey, about the discharge process, the safety net as a planner, a good planner, so that the patient and the family will have a positive experience upon their visit to the hospital. Other areas that you have to talk about is transitional care for young people who are moving towards adult services, as well as consents and confidentiality. When you're talking about your team, remember the nurses, the advanced nurse practitioners, the physician associate, the healthcare assistant, and others. But as well, make your listener understand that you understand your limitation and you will ask for help promptly. Thank you. I think that's the last slide, if I'm not mistaken. Good luck, and there's some links that you can look at that will help you, especially in the area of research and studies that have been conducted recently in COVID-19. So even if you have not been involved, you can refer back to it. Thank you. If there are any questions, I'm happy to answer them, or they can be sent to me and I can write them and send them back.
Thanks, Dr. Sara. We don't have question at the moment, and thanks for covering such a huge topic in such, and you make it very simplified. And as you mentioned, if anyone has any questions or queries, he can contact you, or we are happy as any one of our team to sort that out. We'll still have like 2 minutes. We will wait if any more questions.
Thank you, Khalid. I'm happy anyway to be contacted if there is any question, and if there anybody, especially those who are not in the UK, have any specific questions about clinical governance, and they want to check, that would be fine.
So we have one question now. It's what's about maintaining of mental well-being among COVID? Any approach?
That's a very important question, and you have to take it as when you are talking with parents and children and advising about whether they need to come to the hospital, because sometimes they don't want to come to the hospital. And therefore, you have to triage and make a full assessment whether the child needs to come to the hospital or there is a care that can be provided in primary care. But as well, you have to provide advice to the family if you feel the child needs to come by giving them facts about safety and about what measures will be applied in the hospital to make them safe, because each hospital has got that. As well, you have to be linked with their GP and with the health visitor if you feel that they need additional support. If it's something that's affecting the child themselves as a mental health, and you feel that's something that require an assessment, then you have to make a referral to CAMS. If it's the family or the parent, you have to take their permission and ask them whether they feel like they need to speak to their GP. If it's your colleague or if it's someone of the member of your staff, then you have to speak to the line manager or the clinical director if you feel that someone of your colleague may need to be referred to occupational health.
Okay, thank you. I think our time is finished now. Thank you, Dr. Sara.
Thank you.
So I think we will go ahead. We have a next important topic, and it's about reflective practice. It will be presented by Dr. Mohammed Mutalib. He is a pediatric gastroenterologist consultant at Evelina Children's Hospital, and also I'm not sure if he's around. Hani, could you tell me, please?
Yep, I'm here.
Okay. Okay. Thanks, Dr. Mohammed, also for we know it's weekend and it's difficult to come, but we appreciate that.
ما في مشكلة.
Okay. We can start, I think.
Okay. ممكن تديني كنترول عشان اخد البرزنتيشن بتاعي لو سمحت؟
Yeah, I think Hani is the moderator.
I think you can share your screen directly. You don't need any permissions for that.
All right. Excellent. Thank you. Let me just figure out. Oh, hey, share screen. I got it. Where's my talk? Okay. Can you all see my screen?
Yes, but it's not in the slide view yet.
Should be. Let me try.
Slideshow.
Is it okay now?
Yes.
All right. طيب سامعني؟
Yes, we can hear you.
Okay. في زول ما بيتكلم عربي؟
No, I think all the current ديل تبعنا احنا بعد خلاص الجماعة الخويات كلهم مرقوا خلاص.
اوكي. طيب انا هتكلم عن الريفلكتيف براكتس. هستعمل هتكلم بعربي وبانجليزي combination of both. انه افتكر انه في حاجه مهمه الناس المفروض we need really to know. طيب الغرض من التوك بتاعي الليله is mainly to
معلش يا دكتور لو ممكن تعلي صوتك شويه.
Okay. Let me just get the mic up a bit. سامعني كده؟
Yes, much better.
Much better. All right. طيب أنا كنا الغرض من التوك الليلة إنه to get you prepared for interview. I interview a lot of people. common common themes people في العادة بيقعوا فيها في الانترفيو. You mixed up between actually what happened in real life and what's expected in the interview. Interview is a scenario led زي ال RCPCH exams. It's exactly the same thing. You're not in real life scenario. You've been assessed for everything you say, You've been assessed for every questions or every answer you raised. ده مختلف تماما عن إنه أي واحد فيكم قاعد في A&E لأنه in real life things goes in a different way. لكن في interview scenario أو في MRCPCH scenario, I expect most of you has already passed an MRCPCH. That's why you're applying for ST4. For it's similar principle. You need to give the people who ask you a question, either they be assessor or the interviewer, you need to give them the answer they look for. Then they could assess you. لو فيكم زول عمل ال MRCPCH قريب أو مش الانترفيو قريب, you realize إنه people start writing. بتقول أحيانا بيعينوا لك وأحيانا بيبدوا يكتبوا. They write because they got what they want. فالconcept مهم جدا إنك أنت you have to dissociate between the two. You have to dissociate between what answers you give during an interview and what answers you give during your normal day-to-day activities. They should be the same. لكن لاحظوا إنه training بتاعنا is very different, the background بتاعتنا is very different, so you really have to get yourself out of that of your day-to-day shoes and put yourself into the interview shoes. This is particularly important when there is a tricky questions. So if they ask you a question that is really, really tricky, remember there is no child at the end of this question. So don't be shying away about giving an answer, because your answer is not really directed towards a family. You're not upsetting a family. They're not right in front of you. And that is very, very important. So let's start. What's reflection and what's reflective practice? So reflection, it's a process. It's individualized, it's personalized. There isn't really one size fits all. It's a process by which an individual, and it's really important to think of it as an individual. Everyone has a very different individual reflective practice. You think analytical, again, important, about anything relating to their professional practice with the intention of gaining insight and using the lessons learned to maintain good practice or make improvement where possible. الحاجة دي lacking عندنا شوية في معظم التريننج بتاعنا للناس اللي has been trained في السودان. إنهم we do things concrete. That's how things are done. This is how you carry on doing things. And if there's no mistakes done, then you're doing it right. The concept of reflection practice take you out of that and put you in a different context. اللي هو إنهم there's always, wherever stage you are in, you're in process of a dynamic stage rather than a static stage. There's always different way to improve. So you're doing things, you don't have to reflect on only bad things. You reflect on good things. You've got a pathway that's working really, really well. You still need to reflect because there's always room to improve. So the process of reflection, it's a dynamic process that follows people. It doesn't only apply to ST1, it doesn't only apply to ST4, it applies to all of us. And you use it a constant process you have to put in your portfolio when you're training, and you have to put in your appraisal when you're not in training. And why is it important? ليه بنتكلم عن reflection وليه GMC بخط عليه huge impact on reflection. لاحظ في ثلاث حاجات بيمشوا على بعضهم. As an organization, as a team as a whole, you reflect on the quality of the systems. If you look at yourself, put yourself into an organization as a huge organization, all coming together, you have multiple teams coming, you have multiple systems coming, you have multiple sustainabilities going different ways. What is important is you need to learn the lessons and you need to make changes to improve what you deliver, because that will provide a safer culture, that will provide a better patient care, and that will provide a better system. For you as an individual, and particularly in healthcare, you need to reflect on the quality of care that you deliver, and you need to learn from the lessons, and you need to make changes. Why is that? Again, that will provide a safer culture, it will provide a better patient care, but also it will make you a safer professionals. لأنه إحنا بنمارس طب في الآخر, things always are prone to unpredictability, are prone to safety issues. فأنت you need to learn and you need to find out always how to improve things. And as a leadership and as an educational aspect, you need to also to provide a safe systems, you need to provide a better patient care, and you need to provide better professionals. A GMC عنده huge emphasis على reflection and reflective practice practitioner, which is standalone guidance. It's called guidance for doctors and medical students. So even from medical students, we expect medical students to reflect. ولو فيكم أي زول practicing في UK، لو فيكم أي زول it's a clinical supervisor لميديكال ستودنتس، بتلاحظوا كل البورتفوليو بتاعت الميديكال ستودنتس في السنين الأخيرة فيها you have to have a reflective practice before you move on from one module to another modules. So reflection is very important. Reflection is really vital. And a difference بين training people لو فيكم أي زول trained in the UK undergraduate training in the UK الحاجة دي ingrained in your mind. It just comes to you as natural. بالنسبة لمعظم الناس they've not been trained in the UK particularly for undergraduate training of the UK الحاجة دي ما مخطوطة عندنا في الكوريكولم زي ما أنا قلت لكم early. You need to learn it. You need to learn it. You need to learn it in the right way. لو فيكم ناس قاعدين لهم فترة هنا الكيس بتاعت بابا جاربا اللي هي الريفلكتيف نوت بتاعتها led to a court appearance خلت الناس جزء كبير من الناس يفكروا انهم to rethink about what actually how honest I should be in my reflection. وزي ما سارة قالت قبل شوية في التوك بتاعها وذات led to انهم بعد ذاك حاجة اسمها duty of candor اللي هو duty of candor it's an acceptance and honestness and openness and accept mistakes has happened and accept your role and responsibility for mistakes has happened. لكن there is a fine line. Your reflection is not about mistakes acceptance. Reflection is not about acknowledging and mistakes or acknowledging your part in doing things wrong. Reflection is a reflect on the whole of the process and see if there's any ways that it can take you over. And it is not only for negative, it's for negative and for positives. لو في عنده سؤال just please shout it off or write it في chat while we're talking. And I thought إنه بعد ذاك what will be the best way إنه إحنا نتكلم عن reflective practice. Reflection is a huge topic. بيعتمد على إنه إحنا بنتكلم عن reflection ليه. كل الناس الشغالة في UK وعندهم portfolio أو عندهم non-training عندهم portfolio for non-training doctors, they have to have a reflective at some point. Education supervisor بتاعكم يقول لكم ادونا reflections. والناس اللي ما شغالة في UK يفتكروا إنهم الكونسبت. أنا مثلا لما جيت البلدي وقعدت تقول لي اكتب reflection I have no idea يعني شنو reflection. Why do I need to reflection؟ خلاص الحصل يعني. فقلت أنا أفتكر إنه كده لو ناخد مثال في الموضوع ده ونشوف إنه ممكن نصل كيف لإنه how would we reflect on المثال ده. 4-year-old non-epilepsy gel A&E by prolonged seizure, subsequently admitted to intensive care to PICU following a respiratory arrest. Inter put a registrar on call for that weekend when he arrived in A&E about midday between the child arrival in A&E and their respiratory arrest. In the course of management of the child's seizure, they received 5 doses of benzodiazepines. The child was then given a loading dose of phenobop, which quickly stopped their seizure. The on-call consultant arrived as the child is being admitted to intensive care. Any questions for history there? Anything striking you at all? No? Okay.
I think the question
في زول قال حاجة؟
I think
معلش.
we have a lot of talking about 5 doses given.
5 doses, yeah. So why
Absolutely.
5 doses?
5 doses. Correct. أنا ما قادر أشوف
And
did
someone
anyone
mentioned about ABLS guidance was not followed.
Okay. Let's get the second part of the questions, then we stop for a discussion. It was not until the child had arrested that the number of doses of benzodiazepine that the child had already received was clarified to all the staff managing her care. These had been given by different staff in different places during the episode. At home from the family, in the ambulance from the paramedics, in A&E from the A&E medical team and nursing team, and again by the pediatrician who came to see the child at a later stage. It's likely the likely cause of the respiratory arrest was the number of doses of benzodiazepine received. The child needed a short period of intubation and ventilation, but fortunately made a full recovery. Okay, طيب let's stop هنا ده talk a little bit عن الكيس ده. Anyone wanted to add anything? Anyone wanted to raise any point?
Someone mentioned about there is no proper handover communication. I think to a lot of the same now, no communication, lack of communication, handover issues, miscommunication.
Absolutely. Correct. So there is issue with communication. Yeah, I can see the chat now. Yeah, and now I can read in the chat. So there's miscommunication, absolutely correct. There's communication handover issue. There is lack of communication, lack of communication. Okay. لما سعيدة if لو قلت اسمك صح ممكن تقول لي what do you mean by lack of communication? You can speak, you don't have to write.
Yeah, hello. So part of the handover was to say that the child received any medication or not. If there was history taken from the family, they would say that they given some medication, the ambulance to the emergency department, and from the emergency to the handling staff. Nobody mentioned apparently that the child received benzodiazepine before, and she kept receiving, because she continued to see them, she kept receiving a dose after dose after dose.
Mm-hmm.
And this all led to her respiratory arrest.
Do you think mistake was happened?
Yes.
Okay, and who made the mistake?
It's multi-level.
Mm-hmm. Okay.
Mm-hmm. So it was multi-level from the ambulance to the nursing, to the emergency, to the last team.
And what do you think? I'm just quizzing you a bit more. What do you think the mistakes were happened? Because the child was fitting, so they have to give something.
Yes, but the guidelines says clearly that we need to give 2 doses of benzodiazepine because of the risk of respiratory arrest. Mm-hmm. And because of not following this guideline, this led to the child going to the respiratory arrest. And in the scenario that she received, I think phenobarbital, and seizure stopped after that. So if you follow the guidelines, maybe she might require more medication, but she wouldn't go through cardiac arrest, respiratory arrest.
We have 5 minutes left, sorry.
5 minutes for the talk, okay. I thought I had 20. All right, fair enough. So let's move on to the rest of it then, and we can discuss that outside the meeting. So you've identified the most important area of all of this. So it was not, okay. So the pediatric consultant then discussed with the pediatric registrar, and together they discussed with the colleagues in A&E and the pediatric unit. It was flagged as an EMS, the incident through the hospital safety reporting system. As part of the duty of candor, the registrar, supported by the consultant, explained to the family what has happened, where had been an error, and why this has resulted in respiratory arrest. So discussion included an apology and explanation for the incidents in the incident reporting system of the hospital. So that's wrapped up the incidents. That wrapped up what has happened for the child, and we've discussed the salient point of the process throughout what has happened. So what reflection? Reflection, there's too many ways to do reflection. There isn't really one right way and one wrong way. And I thought I will just bring one of the areas I find really easy, the Gibbs method of reflection, which you describe what has happened. And the second step is your feeling. See what were you thinking and feeling? Then you evaluate what was good and bad about the experience. Then you analyze what sense can you make of the experience. Then you conclude, which is what do you need to improve on? And then your action plan, how will you improve? And then that will take you back again into the same description. So it's a cycle of reflection. And what the trigger for this, it doesn't always have to be a mistake. The trigger could be good things, and trigger could be less of the good things. So I thought if I put myself into the registrar's shoes and I was asked to write a reflection, my thinking will be, I could write something like that. I was involved in an incident. The patient had a respiratory arrest secondary to repeated dose of benzodiazepine at home and at hospital. The patient was retrieved to a PICU, ventilated for 1 day, and discharged after a full recovery. Unfortunately, the family did not tell us about the diazepam they gave at home, and the paramedics did not tell us about the midazolam they gave in the ambulance. I explained this to the family. I was happy I had explained everything to them and continued with my other job. That's what I would write. And I thought that followed the description, the feeling, the evaluation, the analysis, the conclusion, and the action plan. Okay. I'll stop here. I think I have a couple of minutes. What do you think of my reflection? is a reflection only about negative situation. No, it's not a negative situation. Reflection can be about positive and can be about negative. System failure, leadership issue. I've put mistakes on others. Correct. Okay. Anyone else wanted to tell me about my reflection?
It's very short one.
It's a very short. In which way?
Yeah. So in way, I think we need to go in more details. Okay. In areas that needs to be improved also. Yeah. So we have to follow the circle. Yeah.
We have to follow the circle.
Right.
So in a nutshell, this is really, really bad reflection. If that's written in that, this would not be a reflection at all whatsoever. So what is written in front of you is just an example of how you should not do reflection. Okay? Because clearly this is not a reflective. That what I wrote in the slide is I wrote a description of what has happened. I've put myself away. I start blaming everyone around me, and I've started taking the moral high ground. I'm saying, oh, I didn't really do anything wrong with that. It's the family didn't tell me, the PIC, the ambulance didn't tell me, the A&E did not tell me. I didn't do anything. I went and explained to the family, I'm the good guy. No harm done the child. I wrote down in my book and I ticked the box. Okay. And it's you correct, as people have been writing in the chat, this is not a reflection. So what I want you to understand, that is not how you reflect on the things. So I will just in the last couple of minutes before I finish, and I'm sorry I'm over.
We got 2 minutes.
Got 2 minutes. So you've got the 2 minutes. You need to describe. The description should be just describe what has happened and your first task of things. You describe the whole incidents from the start to finish, and you need to describe your feeling. How did you feel when this child went to intensive care, as you're coming across? Why did you, normally when you come to any scenario, as any of you has been in A&E multiples of time, you normally ask about things. You ask about what has happened. You ask about what doses were given, what medication was given. What's your feeling? What makes you, in that time, were you really stressed? Were you really very busy? What was going on within that scenario? What's going on in your mind when you walked into that scenario from the child? Then you evaluate what went well and what did not went well. So there is a number of steps. Everyone did their best intention. So the parent did their best intention of following their protocol. They gave benzodiazepine. The ambulance gave their best intention to follow their protocol. Each person has followed their protocol to their best intention. However, there is something lacking from that. What did not go well, it is no one is talking to each other at the particular time. Why was that? Is that because of the system really failure? That because the child was very sick? Is that because everyone made an assumption? So you need to go into a bit much more details. Why do you think? We can't just blame system failure. What does a system failure mean? Why did people? Because the paramedics normally should ask the questions. Why people had not asked the questions? Then your next step will be to analyze what has happened. What you need to make sense of the experience in the light of your previous experience and the published evidence. A lot of you have wrote in the chat box about the protocols and the guidelines. Who knows the guidelines? What guidelines do you follow? Is your hospital guidelines is aligned with ABLS guidelines? Sorry, there's a lot of feedback. Can you mute your microphone if you're not talking, please? You need to analyze it, and you need to try to make sense from your analysis, because it's not a blame. So reflection is not about finding mistakes and blaming people for mistakes or blaming system for it. Reflection is trying to figure out what are things that went okay and what are the things that did not go okay, and what makes things that don't go okay. And you conclude from them, you analyze them, and you trying to identify ways to improve things. We're not in a court in that aspect, and you're not in a blaming game and finding mistakes and getting people, hanging people out to dry. Then you conclude, and your conclusion should be what could have been or need to be done differently. And that's where your chance not to write your own view about, well, I think in a different settings, because you're reflecting, you're not in front of the child, that should have has happened. And from that, you devise an action plan. The action plan could be as simple as a checklist for people who walks in from A&E for an ambulance and asking what exactly the child has received before. Or what is your handover between ambulance and A&E? What's the handover between the resource team and the pediatrics team, and X and Y and that? And that will take you back again to your last bits, which is your description of the incidents. So that is all of what I wanted to say today. And there is a journey before you become an awesome, you need to practice, and the practice is part of reflection. So I don't know if I have any time to take any questions, or do we need to conclude? Moderator, do I have time for questions? Does anyone have a question?
I think time is finished, but
Okay.
I cannot see any question.
All right. Excellent. So for the one
So
I will see later.
Do we have any? I have a question, guys. Hello.
Okay. Yeah.
بسأل هل عندك sample for this scenario for reflections?
Yeah, I have.
As a sample يعني.
As a ideal answer.
Yeah.
Yes.
Yeah. Thank you.
لو انا خطيت الايميل بتاعي في الشات if you can email ما اعرف اللي بيتكلم منه بصراحه معلش.
معك محمد امين.
محمد طيب. ده الايميل بتاعي. If you email me,
okay.
I will email you what is the right answer for this question. Right.
شكرا بوس شكرا.
يعطيك العافيه.
I think thank you, Dr. Mohammed. I think this is one of the best, even for me. I'm now pediatric trainee, was one of the best lecture about how to reflect, and it's not only for the candidate who's going. I think even us, we benefit from this lecture. Thank you a lot.
يديك العافيه. So I'm happy زي ما قلت لكم I'm happy انكم to contact me. That's my email address. Please feel free to write an email. لو فيكم أي زول has been shortlisted, feel free to write to me directly. For the people I will meet later on, for the mock test, we can discuss a bit more details. Good luck for everyone I don't meet later, and hope to see you sometime. Assalamu alaikum.
Thank you.
Bye.
Thank you for all the speakers, and it's time to have a break and eat something if people are hungry. It's now 12:05. I think we are around maybe 5 to 10 minutes behind the schedule, but that's fine. If we split now for a break for about 20 minutes, maybe we can come back at 5 before 12:30, maybe 12:25, 12:30 for the mock sessions. If I may ask everyone to stay on the chat, so stay on Zoom logged in, because the hosts and the moderators will split you into the rooms. So when you come back, you will find yourself into your own mock session room. As groups, you will be split into 5 groups, and you will be, so all rooms will be separate from each other. Each room will have its own scenarios and its own practice. Again, if you have any questions or anything else, you want to put it on the chat. Meanwhile, that's completely fine. You want to email to us, also good. And if anyone has got anything before we go to break, I think we just need to go to break to make use of time. Shall we just convene at 12:30? Is that okay? Good. So don't leave the chat. Stay on it, because we will split you.